Hello friends, welcome back to my channel with a new video. And this particular video is on preeclampsia and eclampsia and severe preeclampsia. So this is a particular talk which I delivered during the Kochi National Conference, and which was just held recently in the month of March 2025. So again, I have divided it into two parts, and so let us start with the part 1. And so this is a case of 23-year-old female, 30-week pregnancy, has seizures, epigastric pain, decreased urine output, that is about 300 cc in the last 24 hours. She also has pedal edema with the blood pressure which is raised with 190 by 110. The urine routine shows 4 plus proteinuria and hemoglobin of 8, which is clear cut. There is anemia, and SGOT and SGPT are raised. So what is the likely diagnosis, and how can we define a preeclampsia and eclampsia? So clearly, preeclampsia, or also called as pregnancy-induced hypertension, is the presence of hypertension above 140 by 90 on two different occasions, at least 6 hours apart, in more than 20 weeks of gestation, in women with previously normal blood pressure and who have proteinuria, that is more than 0.3 grams protein in 24 hours, with or without pedal edema. So each and every word in this definition is important. And what is eclampsia is seizures that cannot be attributable to other causes in a woman with preeclampsia. So it's not very difficult, but the definitions are very important to understand. So if you go on to see, preeclampsia is a kind of a multi-organ problems, and this happens due to the reduced vascular tone, and because of this there is an effect on the cardiovascular system. There is a capillary leak, there is decrease in the filling pressures, increase in the systemic vascular resistance, and of course decrease the QT, that is the cardiac output. And definitely it has an effect on the liver, on the uterus, as well as on the kidney. And actually, if you want to mitigate these problems, of course we know that the magnesium is something which is definitely used, and these are the two actions of magnesium which will have increase in the prostacyclin, and which will cause vasodilatation, which is the major problem of vasoconstriction which is seen in this preeclampsia. And it also acts on the sodium potassium pump, which you can see here, and we will discuss about magnesium later. So severe preeclampsia is defined as SBP which is more than 160 or higher than that, or diastolic pressure 110 or more than that on two occasions at least 6 hours apart, proteinuria of more than 5 grams in 24 hours, or 3 plus proteinuria on two random samples collected at least 4 hours apart. There is pulmonary edema or cyanosis, oliguria which is about 400 cc or less in 24 hours. Patient has thrombocytopenia, features of DIC and HELP syndrome, persistent headaches, epigastric pain and impaired liver function, oligohydramnios, decreased fetal growth, and of course placental abruption. So these are all the features of severe preeclampsia which we just saw. And this is important because it is not that the patient will only have these particular signs or symptoms. They can combine with each other, and you need to actually address the clinical problem holistically. So if we ask another question, what are the key factors on clinical examination which are suggestive of end organ dysfunction in patients with preeclampsia? And we saw that the in preeclampsia, because of the increase in the SVR, there will be decrease in the cardiac output, and it can affect the majority of the organs, including the brain, liver, uterus, and as well as kidneys. So probably these are the aspects which are relevant to history and examination. So a pregnant woman with antenatal evaluation, we need to have history of immunization, whether there was hypertension, and also the PI during the previous pregnancies. What are the complications and outcomes of the previous pregnancies? Does the patient have headaches, visual disturbances, altered mental status, blindness, dyspnea, edema, epigastric or right upper quadrant abdominal pain, weakness or malaise, which are suggestive of end organ effects? And on examination, whether the patient has altered mental status, vision related issues, papilledema, epigastric or right upper quadrant tenderness, edema, seizures, and all the features suggestive of end organ dysfunction. Now, as far as the investigations are concerned, of course, we need to send complete blood count with examination of the peripheral smear, the liver function tests, the kidney function tests, serum electrolytes including magnesium, arterial blood gas, random blood sugar, coagulation profile which includes PT, PTT, fibrinogen and D-dimer, LDH, uric acid. Importantly, don't forget to ask for urine routine, the 24 hours urine protein and the creatinine, of course, the sonography and the transthoracic echocardiography. So this actually, we need to ask another question is to what are the differential diagnoses of preeclampsia. So they can be either abruptio placenta, abdominal aneurysm, acute appendicitis, blunt abdominal trauma, cholecystitis and biliary colic, or encephalitis, hypertensive emergencies, ovarian torsion, status epilepticus, TTP, or any poisoning. So all these are important to be considered when you deal with the patient having these kind of symptoms. So what can be the differential diagnosis for eclampsia? So don't forget that we have seizures here. So any CVAs or brain tumors, brain infections like meningitis, encephalitis, abscesses, TTP, metabolic disorders, hypertensive encephalopathies, drug overdose, post-dural puncture syndrome, epilepsy or PRES, all these can be differential for eclampsia. And so what are the different indications of ICU admission? So these patients, anyone who has obstetric hemorrhage, either in the form of placental abruption or placenta previa, severe preeclampsia and eclampsia by definition which we saw, features suggestive of hemolysis, high liver enzymes, HELP syndrome, chorioamnionitis, acute pulmonary edema, respiratory failure, ARDS, and of course ARF. So all these are definite indications for ICU admission. And remember, any patient of yours who has these features, don't forget them to admit them in ICU. So that's all for now, and I'll come back to you with the second part of this particular topic. And take care of yourself. Bye bye.